This lecture is going to be about joints. Joints that are found between two articulating or communicating bones. So now that we have an understanding of bones and know some of the most common bone names and locations for those bones, we're going to take a look at where they actually meet. These joints provide movement, and that is the major function that we think of with joints, and where two bones actually meet. And there are different types of movements that we think about as far as how they are classified. So we're going to look at the classification of those joints. We're going to look at the different anatomy of those joints, and that anatomy dictates the function that's going to be seen at that particular joint. We'll look at what's normal first, and then we'll also touch on some pathology that we associate with joints. So the terminology that is basic terminology that you should have when it's concerning joints is arthrology, is the study of joints, arthrology. Kinesiology, I think most people know that kinetic energy is the energy of motion. So kinesiology is actually the study of movement or motion. So it is going to involve the muscles that are needed for movement, the attachment sites of the bones of origin, which is the bone that won't be moving, the bone of origin, and then the bone where that muscle attaches to that will be acted upon, which is called the bone of insertion. So bone of origin is the bone that won't be moving. Bone of insertion for that muscle is the bone that will be acted upon and will be moving. So you look at all of those things. You look at the innervation of those muscles. So kinesiology is really the study of what it takes to have appropriate movement at a particular joint. They are classified based on their movement, and so there's some terms that we would want to know and understand. A diarthrotic joint is a joint that has free movement. Most of the ones that we think of that are diarthrotic are what we call the synovial joints, where we see lots of movement. The movement is actually visible to us. So the synovial joints are usually the ones we think of as being the diarthrotic joints. There are some joints that have very slight movement, though, and those are referred to as amphiarthrosis joints or amphiarthrotic joints. And then syn as a prefix means without. So synarthrosis means no movement or very little movement, nothing that you could really see. So in this classification, we have these tables. Scientists like to classify and like to set up tables to organize things. You would never need to memorize this because you could always refer to your information to figure out what classification a joint is. But it does give us a basic idea that as far as the structure, which we know structure dictates function, anatomy always is going to help us with physiology, isn't it? So we could look at some of these and see how this classification actually holds together. So let's first look at some of these basic structural classifications, taking a look at the ones that we see a little bit less movement, and then working our way to the more complex joints that are the synovial joints or the diarthrotic joints. So the first classification to look at, we're going to look at are the fibrous, cartilaginous, and bony joints. So fibrous joints are just what they suggest. They are going to be joints that have these collagen fibers that are spanning between them, holding the two bones together. We have some examples of these. The ones I'm going to want you to know are sutures, which are actually only found. I'm going to go to the next slide to show you these. Sutures are only found in the skull. So in the skull, those cranial bones that make up our skull we're going to find these joints that we refer to as sutures. Not all sutures are created equal as far as their anatomy goes. There are different classifications. That's just for your information. I'm really not going to ask you about serrated or lap or plain sutures, but it's really just in their anatomy that we see the differences here. So like a serrated knife fitting in with another serrated knife. That's what where we see here between the frontal bones and the parietal bones, we can see this serration type of joint held together by fibers. There's also some sutures that we see lapping over each other, and here between the sphenoid bone and the temporal bone, you can see that. And then there are some sutures that just butt up against each other. They just butt up, or what are called plane sutures, such as in the maxillary bone, this hard palate that we see. So there are different classifications of sutures, but mostly I want you to know that there's very little movement. There is some movement. There's some movement. Just very little movement once the skull has reached full adult potential. We learned in our previous section on the bones that as a skull is growing in an infant and a toddler and a child, the spaces that are still present and visible are called fontanelles or soft spots. But as the bones end up coming together, they form these joints that are known as sutures. Another type of fibrous joint that's very important that you know are called gumphosis. These gumphosis joints are only found holding teeth to bone. So holding a tooth to the bony structure are these ligaments that we refer to as periodontal ligaments. And it would be important that you know that the joining of the tooth to that bone is called a gumphosis joint. The most common cause of tooth loss, a lot of people think it's because of cavities or what in medicine is known as dental caries, but that's not true. The most common cause of tooth loss is actually advanced periodontal disease, which is the loss of these ligaments that you can see them here. They've been blown up for you. This little box has been blown up. You can see, ligaments attach bone to bone we think of, but in this particular special joint, it's bone to tooth. So these periodontal ligaments get broken. And if they get broken, then no longer is there going to be any pressure on the tip of this bone when you are chewing on naturally hard substances, which is actually healthy for the periodontal ligament. But if this gets broken and broken and broken, then the bone loss starts to happen because there's no pressure on it. So the bone starts to actually sort of dissolve away. And then the tooth gets loosened and that there's no holding it in place anymore. So there's a little bit of wiggle room, not a lot of movement, but a little bit of wiggle room for sure. Now, the last fibrous joint, and I don't really ask you all about syndesmosis, but the last fibrous joint is actually a membrane that is found between like the radius, which you all know is a lower arm bone in the forearm that connects to the humerus, the distal end of the humerus, and the thumb, if you will, the radius, and then the ulna. So as you pronate your hand, moving your hand in the posterior position, this actually is a membrane that allows for that movement. So cartilaginous joints are joints that, as you would imagine, are attaching two bones with a cartilage interface. Not all cartilage is created equal. There's some different types of cartilage, but we know that cartilage cells are called chondrocytes, and chondrocytes come together to form this connective tissue known as cartilage. And again, there are different types of cartilage, but mostly just wanting you to know that some joints are held together by these cartilage pads. And between vertebra, there are the intervertebral cartilaginous disc that we see, these fibrocartilage. In this os coxae, the right os coxae, or hip bone, and the left os coxae in the anterior, or the front image of that, you can see between the pubic regions of the os coxae, there is a pubic cartilaginous fibrocartilage pad that is softening that connection. As we know already, bone, mature living bone, is 2/3 inorganic calcium complexes, which makes it hard. So you wouldn't want two bones meeting anywhere, articulating, communicating, meeting anywhere where they would be sitting on one another without some sort of interface, or that can cause pathology at that particular site. There are some joints that when the bones are maturing will ossify. And this we've already addressed as well when we said that infants are born with about 270 bones, but as we get to adulthood, we have about 206. Well, we didn't lose any bones, but what happened is those bones ossified and came together. This happens at a very particular age, a normal kind of aging process. This is how, when we find bones of someone who is deceased, we can kind of judge when they died by what kind of ossification process had already happened in these bones that we know end up ossifying by certain ages. So once the bones fuse, then obviously there would be absolutely no movement at that particular site. Okay, so the majority of this session, this chapter, is dealing with those joints that we see between two bones, where there's actually quite a bit of movement, free movement, what we call diarthrosis or diarthrotic joints. And those joints belong to a category that we talk about being synovial joints. A synovial joint, no matter where it might be, whether it is between your phalanges, maybe your proximal and medial phalange, or the medial and the distal phalange, or whether it's the wrist, or at the shoulder, or the elbow, or the knee, wherever, there's really free movement, and they all have certain things in common. Some of them are a little bit more complex than others, but they all have certain things in common. And let's look at what they all have in common. All of them are going to have in common this encapsulated joint that is going to be enclosed by this synovial membrane that actually, within the capsule, there's going to be a secretion of a fluid we call synovial fluid. And we'll take a look at what synovial fluid is made of, and also just its function in just a second. But all synovial joints, even little ones that you think of, like here in the distal phalange and the medial phalange, all of them have this encapsulated, these ligaments and this encapsulated synovial membrane that's secreting synovial fluid at a constant rate. And then the synovial fluid that's already there is being kind of reabsorbed at a constant rate. So it's constantly replacing itself, and that pace needs to stay exactly right for the health of the joint. All synovial joints at the ends of the two bones that are meeting have a pad of cartilage as well. So at every synovial joint where the two bones are meeting, there is this padded piece of cartilage at the ends of both bones. This is referred to as articular cartilage because it can't, again, articulation means communication, and communication means the meeting of these two bones at this particular site. So this is what all synovial joints have in common, and there is this cavity that is filled with synovial fluid, lubricating and keeping the joint healthy. The pads are keeping the two bones from actually touching on each other. As we age, it is a natural process of aging with normal wear and tear for these articular cartilage pads to thin out. The most common joint disease is due to this natural thinning out of the articular cartilage. This disease is called osteoarthritis. Osteoarthritis, that's one word. Osteoarthritis is actually sometimes referred to as old age arthritis or wear and tear arthritis. That's what you'll hear it. But the medical term is osteoarthritis, and it is a normal aging or wearing and tearing of of a normal process that's happening in the joint. Now, there's ways we can prevent the acceleration of that. We can take care of our joints by making sure that before we're actually really using our joints, we warm up. When we warm up even a percentage, a fraction of a degree, when our body is allowed, our joints are allowed to like warm up before we do something extreme, this synovial fluid actually warms up enough that the cartilage absorbs it. And as the cartilage absorbs it, just like pouring water on a dry sponge, the cartilage will expand. So if we warm up our joints, our articular cartilage can do even a better job than it would do if we just went at something aggressively and cold, because then the cartilage can get worn down more quickly. But anyway, all synovial joints have this. They are the most freely movable. And now we're going to look at a couple of things that very particular joints might have because of what's needed at that particular site. As you can imagine, and again, this talks to you a little bit about what articular, the capsule is, what synovial fluid. Let me talk about this again. This, if you were to pull, and sometimes you need to get synovial fluid off of a joint because it's swollen, and you're trying to figure out what's causing the swelling in that joint, so they can go in with a needle and aspirate synovial fluid. It should look clear and colorless, and it has the feel of maybe a raw egg white. So that's what I feel that it sort of feels like, sort of slippery and lubricating. But it is very, very rich in these proteins that help with healing, and hyaluronic acid, which is also protective for it. And hyaluronic acid is actually very much an absorbent substance, so if there's water present, it absorbs and expands. So all of these things are very, very viscous. Just means thick and slippery. That's all that means. But that's the way we think of as normal synovial fluid looking. If there's infection, we would see it clouding. We can sometimes see bleeding in it, which we shouldn't see. We can see white blood cells and red blood cells, and then sometimes microbes will actually grow out. So that is not something you typically want to see. It should be clear, colorless, and sort of slippery. Now, the articular cartilage, we said, also needs to be of a certain amount. If it is thinned out enough that the bones are now hitting each other, they're going to be spurs, bone spurs that are actually here. So any movement at all is causing pain. I just gave you the name of the most common joint disease. It's osteoarthritis. I want to talk to you about a second now about another term that is often used, and that term is simply arthritis. Arthritis means inflammation of a joint. I mean, we would literally break that word down, and that's what it would mean. Itis means inflammation. Arthro means of a joint. So that is not a diagnosis, though. That just means there's inflammation of a joint, but now you need to find out why. There are a lot of things that can cause inflammation at a joint. Injury can cause inflammation at a joint, so there could have been trauma. So arthritis is just this umbrella term, but it's not a diagnostic term. So when someone does have pain or inflammation of a joint, then it's up to the medical community to try to help to figure out why. As we said, the most common reason that people come in with pain in their joints is osteoarthritis, normal wear and tear, aging of a joint. But it can also be an autoimmune disease. And we know that autoimmune diseases means that the person's own immune system cells start attacking their own tissues. And in this case, it's the tissues that are necessary for good joint health. So some examples of autoimmune diseases that attack joints, the most common is rheumatoid arthritis. Rheumatoid arthritis is very different from osteoarthritis. It is an autoimmune disease, and it can actually occur at any age. It can occur in young children, childhood RA, they call that rheumatoid arthritis, and it most commonly occurs between 20 and 40 years old It's most often seen in women, but it can be seen in men as well. And when it is diagnosed in an adult, it is a lifelong diagnosis. So like with a lot of autoimmune diseases, they come in and out of remission, like your immune system will be hyperactive at one time, but then it calms down. But some people who get diagnosed with rheumatoid arthritis end up in a very short span of time in wheelchairs and have really lost mobility. Others with rheumatoid arthritis can handle it pretty well with medication and, doesn't so adversely affect their lifestyle. So as with most autoimmune diseases, there's this huge spectrum that we see as far as signs and symptoms of the diseases. So that's one that can attack the joints. There's another autoimmune disease that can attack the joints called lupus. There's another autoimmune disease that can attack the joints called psoriasis. So there are quite a few autoimmune diseases that we know that can actually end up impacting the joints. There's also infections. Bacterial infections can actually go to a joint. So there are a lot of different things that can cause pain in the joint. Arthritis is simply just a descriptor of pain or inflammation in a joint. Now, in some joints, there are these special extra fibrocartilage pads that you find in the joint. These are called menisci, or meniscus is plural. And these little pads, these little extra pads, I'm seeing if I have a picture of an extra pad. Well, these little pads that are found really are extra little cushionings that you find. And as you can imagine, they're going to be in joints that have to withstand a ton of pressure. So joints that have a lot of pressure put on them, like your knees, your jaw is actually one of the most powerful joints in the body. The sternoclavicular, so sternum and clavicle where that meets, believe it or not, that's a lot of pressure, because often when we fall, we catch ourselves with our hands, and all of that kinetic energy ends up coming to here and stopping right at that point. So there can be a lot of pressure there. So it's absorbing shock. Not all joints have menisci, but the ones that have to have a lot of pressure do. Tendons, I've already told you, are connective tissues that attach muscle to bone, and ligaments are connective tissues that attach bone to bone. So the tendons are attaching the muscles to the muscle to the bone of origin and the bone of insertion, and as that movement happens, there's going to have to be a glide over that. And ligaments are stabilizing, attaching bone to bone and stabilizing the joint. So that's their function. Now, there's something else that we often see. We just said that tendons are attaching a muscle to two different bones. Tendons are going to help, tendons do that, but bursa are these sac-like extensions of that are going to help that with the movement of the joint happening, it's going to help for that tendon to slide across when that needs to happen. So these are fluid-filled, synovial fluid-filled sacs that help with the movement of those tendons across the joint as the joint is changing shape and structure. So we have bursa, we have menisci in some joints, we have tendons and ligaments we think about with the joint, we have the synovial membrane, we have articular cartilage. Synovial joints are really complex, even the little tiny ones like we think of in our toes and our phalanges. They're fairly complex joints because we do need the movement associated with them. Now, as far as classification of movements, I am not going to ever give you a joint and ask you to tell me whether it is ball and socket, hinge, saddle, gliding. I'm not going to ask for that. I'm just letting you know that not all synovial joints have the same type of movement, which I think you already probably know. So, but let's just talk about a few of them. A ball and socket these joints are named by what you think of as the movement, and they're very intuitive to think of. It's nothing that you have to memorize. It's something that you just know from the name. So like a ball and a socket joint is going to be like a ball fitting in the socket. And we have a lot of movement associated with these joints. The shoulder and the hip, the leg, you can rotate that. A hinge joint is just like the hinge on a door opening, a hinge or cabinet. It's mono, meaning one axis, so it's just like a hinge. Saddle, where we find a saddle joint is at the thumb. We have opposable thumbs, so we can take our thumb and touch it to the pads of our other fingers, and that helps us to be able to pick things up. And actually, we know primates have an opposable thumb, don't we? A pivot joint is just what you think of with a pivot. At this proximal end of the radius and ulna that is meeting here in the elbow area with the distal end of the humerus, the radius and the ulna have this little area that they pivot. This is why you can actually pronate your hand. So that movement also is incredibly important. So is the atlantoaxial joint, which is between the atlas and the axis, C1 and C2. At this time, you have learned the bones. That was the first cervical and the second cervical. So that you know, we have this movement, this that you think of with the axis and the atlas, this no movement. All right, pronation and supination. Gliding joints, it's hard to imagine, but these tiny little irregular bones of the carpal bones in the wrist and the tarsal bones in the feet, it doesn't look like there'd be much movement, but there is some movement. It's kind of limited, but there is movement here between these carpal bones, as an example. Condyloid, again, I'm not going to ask you to list these. I'm just letting you know that because of the anatomy, the structure dictates the function. We want to keep the health of the anatomy because it means that we would keep the function of the movement. We don't, you don't really miss something until you've lost it. But patients who have, through pathology, through disease, or through trauma, that have lost their mobility at any particular joint, it can be life-changing. Any of these loss of these mobilities can be life-changing for them as far as quality of life. So the condyloid or ellipsoid are biaxial, and so you can actually see here with the metacarpals and the phalanges that you have that. Now, what I am going to want you to know, and you will need to know as far as a lab, a joints lab goes, you will have a quiz on, and this will also be a lecture quiz, but that you will need to know these terms that we associate with the movement, the different types of movements at a joint, because this terminology is used in patient reporting, and this terminology is used when someone has lost certain mobility, which is called range of motion. So you would really need to understand this terminology and be able to use it in a working form. So, and understand it in a written form. So you would want to be able to very much converse about these particular movements. Now, as far as the joints go, if you think about someone in anatomical position, which you all know now from your second lab that you had, it means someone standing with their feet shoulder width apart, their palms facing forward, and you're seeing them from an anterior position. All of the movements we're about to talk about, all of these movements we're about to talk about, are movements that we think of from anatomical position or to anatomical position. So you have to think about that. Also, the range of motion that we associate with this range of motion can be measured. It's measured with a very simple little instrument called a goniometer. That's going to be in the notes in a second so you can spell it, but it's in your PowerPoint. A goniometer. So it's just really looking at the angle. So if you think about a person, and this person has raised his arm here in a lateral way, but if you think about his elbow being flat here, this could be measured as about, 180 degrees. But if he pulls his hand up toward his shoulder, this is decreasing the angle. Now it's at about, what, 45 degrees? So decreasing the angle of a joint from what would have been considered anatomical position, because in anatomical position, your elbow is straightened out, isn't it? So decreasing that is called flexion. Extension means going back to anatomical, returning to anatomical position. Again, all of this terminology is based on either going from anatomical position or back to anatomical position, or even hyperextending. So hyperextension of a joint is going beyond that. Now, an elbow should never hyperextend. There are some joints that can hyperextend. So if you think about, like, at your wrist, of course you can flex, you can extend, and you can hyperextend. So there's some joints that hyperextension is normal, and other joints like the knee or the elbow, you would never want to see hyperextension at that joint. So flexion, extension, and hyperextension. So they're kind of showing you that. And it's important to look at the difference here. Abduction versus adduction. Abduction is moving away from the mid-sagittal plane, and you all remember with the mid-sagittal plane, the mid-sagittal line is here. So moving away is abduction. Adduction is moving it back. So you can also do that to your fingers. You can abduct the fingers and then adduct the fingers. Elevation is raising. Depression is, lowering. So some of these are so self-evident. Protraction is moving something forward along an anterior plane. Retraction is moving it back. So moving your jaw forward or back. I'm probably making funny faces here. But sometimes when you're studying this, if you actually move, kinetic learning is actually a real thing. This is why I think sometimes like ABCs should be taught while kids are doing jumping jacks or running around playing. So anyway, kinetic learning. So protraction, retraction. Lateral, you all know, means to the side. Medial means back toward the midline. You learned many of these terms when you were learning that second lab exercise in your McGraw-Hill Anatomy and Physiology Revealed software. Circumduction, just as the name suggests, is making these circular motions, which are really going to be using a sequence of flexion, abduction, extension, and adduction. So we only have this really at the ball and socket joints, so the shoulder and the hip joint. They give you a lot of examples, so you can look at this. You also there's also an exercise you could do in your McGraw-Hill site. So just play around with these terms, making sure that you know all of these terms. Supination and pronation. I know they talk about this with not only the forearm and moving the palm to face, to pronate the palm to the posterior aspect. So pronation, and then supination is returning back to anatomical position. They talk about this with the foot as well. So, they talk about it with the foot as far as supination and pronation. But actually, mostly when you're hearing about this, it's referring to the palm. Opposition, opposable thumbs that primates have, right? So opposable thumbs, and then reposition means going back to anatomical position. Every movement has a movement away from anatomical position and a name for that movement, and then a movement back toward. Dorsiflexion and plantar flexion are terms for the foot. So dorsiflexion is raising your toes like you're going to take a step. You don't want to trip. You have to raise your toes up. So raising your foot is dorsiflexion. going back to anatomical position, and then plantar flexion is like standing on your tiptoes. Every time you take a step forward or walk across a room or whatever, you're doing a series of dorsiflexions and plantar flexions. And so being able to do this is something that we, again, take for granted until we've lost the ability to do it. One of the very common things that happens as we are aging, you all know that diabetes mellitus type 2 is a very, almost an epidemic numbers right now in our population, especially our aging population. And that is a metabolic disorder where you cannot use glucose the way that you should. And so glucose levels stay pretty high in the bloodstream. What happens is that over time, and this doesn't have to be, such high levels, glucose in high levels, staying in high levels and not being managed, causes neuropathies, which means poison essentially to the nervous system. So over time, the nerves that actually innervate the muscles that you are telling to lift your foot up and walk start to not work as well. So you can lose some of this. So as we age, and it's not just from diabetes mellitus, but there are other conditions as well, some medications depress the nervous system, will cause older people to trip and fall more frequently. And it's because of the nerves that need to communicate with the muscles that end up raising your foot so that you don't trip when you fall. Okay, that went into a lot of detail with that, but dorsiflexion is raising the toes so you can take a step. Plantar flexion is pushing down almost like you're on tippy toes. Inversion and eversion are about the soles of your feet, so you can see there's not a lot of range of motion here, but it's needed. So, this is very important because we do need that particular amount of range of motion to have. We're bipedal, so we're walking up, upright on our feet, and we really need health at these joints for that reason. And in nature, surfaces are not level, not in nature. If you don't believe it, take off your shoes and go out and walk in the woods, or hike, Even on a beach, it's not level. So what you think of as being a kind of a flattened surface, it's really not flat. It's kind of, a gradient. There's a gradient there. But unfortunately, what has happened with modern, industrial revolution, we now have sidewalks, we have parking lots, we have floors in our houses. We don't have dirt floors anymore. Most people don't. Well, I shouldn't say that. In developed countries, most people don't. So what has happened is we don't get a lot of natural movement there with the inversion and eversion, and what it can set up for is actually injury to the joint. So play outside barefoot, I guess is what I'm saying. No, anyway, I'm just letting you know that that's really true. Also, the idea that people get put in these shoes very early, and so that can hinder the movement, the natural movement that we should have at these joints. So range of motion, every single joint has been studied, and every single joint in the human body has a particular range of motion associated with it that we should actually have at that joint. And again, it can be measured just in that, what I was talking about with the angle of the 180 to, for flexion, decreasing it. We can just measure that angle with a little simple goniometer. And physical therapists have goniometers in their pockets all the time, just a little paper instrument to measure that range of motion at that joint. But it's really important that if someone has lost the range of motion, again, either from pathology, like diseases like diabetes mellitus, autoimmune diseases, infections, or because of trauma, car accidents, whatever, then that person is helped until they can get that as much range of motion back as possible. Hopefully 100% back. range of motion. Sometimes that's not possible. Now, so we understand every joint's been already determined as to what type of range of motion should be there. And we know that. Now, some people actually are very, very, have what are called double jointed, okay? Those double jointed people, usually the ligaments are not as tight as they should be. That might seem to you to be something that would be beneficial, but actually it's really not. And if somebody has too loose of ligaments, it means that joint's going to be at risk, at a higher risk for injury. Now, we can certainly extend our range of motion by working joints and keeping active and staying flexible. Flexibility is a really important thing to have. That can also decrease the chance of injury at a joint. So it needs to be just right. You need to be moving and flexible enough, but again, sometimes if the ligaments are too flexible, then it can actually hinder you. Now, you all remember from high school or, whatever you did as secondary education, you remember about levers. And what I am going to talk to you about is that I want you to think about every joint in your body as a lever. And there are a few things I'm going to want you to know about this. Your PowerPoints have more information than you probably need. But there are a few things I want you to remember. We use levers to help us do work. You all know that. We use pulleys, wheelbarrows. We use levers to help us do work. Your joints are levers. And so they give you a mechanical advantage. That means they give you the ability to do work. And this mechanical advantage that a lever can give you will either be power or it will be speed. So I want you to think about that. The mechanical advantage will either be speed or it will be power. And every joint's already been measured, and they've already determined what type of lever you have there, whether it's a first, second, or third degree lever. I'm not going, and I'll show them to you, but I'm never going to ask you the difference between first, second, and third. But I just want you to know every joint is a lever and has been measured, and it has been calculated what type of lever it is and what type of mechanical advantage you get there. So the way that it's calculated, and I kind of want you to know this just because it'll keep in your mind that your joints are levers. Mechanical advantage, MA, is equal to the length of the effort arm in the lever divided by the length of the resistance arm of the lever. And if that number that is achieved is less than 1, you will have speed at that joint. So speed at that joint. If it is greater than 1, you will have power at that joint. Power. So mostly what I want you to get from all of this is MA, mechanical advantage, is equal to the length of the effort divided by the length of the resistance. If it is less than 1, speed. If it is greater than 1, power. Now, again, that's what I want you to get from this, that joints are levers. I'm going to just show you and sort of remind you of how they end up, in the physics of this, just end up figuring this out. First class joints have the fulcrum in the center. Second class joints have the resistance in the center. And third class joints have the effort in the center, right? But those are the 3 classes of joints. Again, that effort arm can be measured. The resistance arm can be measured from the fulcrum. And that's what they use to determine what kind of mechanical advantage you have at that particular joint. And again, you don't want to lose your mechanical advantage at your joints because it's going to compromise your quality of life. So the rest of this chapter is actually looking at some of these particular joints, and it certainly goes into a lot of the anatomy of the joints. I'm going to give you some of the basics. Remember, lecture quiz is only based on what I spoke to you about. So just want to look at a couple of these. The temporomandibular joint, so nice that the joints tell us exactly where they are. Between the temporal bone, which you all know where that is at this point, and the mandible. The temporomandibular joint is really one of the most powerful joints in the body. Now, I want to talk to you about something that has been really relatively recently identified in medicine as an actual syndrome, and that is called TMJ Syndrome. Some people say, oh, I have TMJ. Well, we all have TMJ. We have temporomandibular joints. But what they really mean is temporomandibular joint syndrome. Sometimes it's called disease. But what happens here is there's really pathology going on in the joint. And over time, this actually can end up leading to not only inability to open the joint as much as you should, but pain when it's closing and opening. It can lead to headaches, vertigo, which is a feeling of disorientation and dizziness, tinnitus or tinnitus. I say tinnitus. This actually is ringing in the ears, so this constant ringing in the ears. So all of these things can be really, really, chronically can be really disabling. So if you've known anybody who has that, it is usually, we think, caused from malocclusion, which means the bite is off. A bad bite. So that is what grinding of the teeth. Stress can cause grinding of the teeth. So with that constant grinding and the bite being off, it's going to end up hurting the joint over time. And so some of the ways that they address this is with night guards, so that people won't grind their teeth, and or realigning the teeth, so braces, to realign the teeth and fix the bite. So TMJ syndrome I wanted to tell you about. As far as the shoulder joint goes, the only thing I really wanted you to know is that when someone says they have a rotator cuff injury, they're referring to their shoulder. And again, this is a ball and socket joint, so there's a lot of movement, which means there's a lot of potential for injury here. And what the rotator cuff is actually, what this is composed of, are those tendons that are attaching the muscles that are needed for all that mobility. And it's attaching them, and they end up getting torn. So they would go in and they can actually repair these rotator cuff tendons and help to stabilize the joint so that there's not as much pain. Remember, anytime there's an injury to a joint, there's bleeding into that joint. And with the bleeding into that joint, you hope for regeneration, but oftentimes there's calcification that can come in and scarring. And again, when joints get dislocated, every time a joint is dislocated, there's some bleeding into that joint and leaving behind a little bit of scarring. So this is one of the reasons it's so important that when joints are dislocated, that you properly get them back into the realignment as soon as possible to stabilize it. For that reason, sometimes when the joint's dislocated, like at an ankle, that's a very narrow area. So when the joint's dislocated, you could be cutting off blood supply past that point. So all the tissues past that point could be compromised. So those types of dislocations, even more immediate, that they get back into realignment. Anyway, so another thing about pediatric orthopedics is little kids are very prone to dislocations because their joints are immature. The stabilization from the ligaments and the tendons are not holding them the way they do in mature joints. And so again, they're very much at risk. You see little kids sometimes being picked up by one hand, or swung around by one hand or one foot. You see people doing things that the kids are having fun until they're not, until the joints socket, and then it's not. I've seen kids come into the emergency room that they've been being dressed, and as you're pulling their little arms through their clothing, that's just enough sometimes to dislocate an elbow. So anytime a child has a dislocated joint, of course, there has to be an investigation. Sometimes the investigations don't have to go to Child Protection Services, but there needs to be questions asked of the medical team. And if there is a determination that there could be something that caused the dislocation, that they're just not convinced that it was of an innocent origin, then they have to call Child Protection Services in. So joints need to be in there, need to be aligned. They don't need to be dislocated. So the hip joint, you all know that a lot of times hips get replaced in elderly people whose hip joints are breaking down. But anyway, the hip joint is also one that can be dislocated. And if it's dislocated, it's going to, again, it can cut off blood supply to the bone. It, not to mention the pain associated with this, but this can be pretty debilitating. The knee, you all have a deeper insight in this chapter, which you have to read for the test, you know that. But that you're going to see a deeper insight about the knee joint. This is the most complex diarthrotic or synovial joint. It is, and maybe it's understandable because we are bipedal, which means we stand upright, right? And all of that weight is actually put on the knee, and then as we are moving, the knee has to accommodate that movement. So this really is one of the most complex joints. We know that there are a lot of people now having knee replacements. They're outliving their knees. But what we are just seeing now in medicine is that we have people who are outliving their knee replacements. Knee replacement surgery is any orthopedic surgery is there's serious risk to them and they're serious surgeries. But we are now in just the last decade, orthopedics are actually seeing people who are outliving their knee replacements. So they had to have their knee replacement surgery so young in their lifespan. And knee replacements, just like many other replacements, they hope to get 15 years. If they get more than that, they're really happy. But they're outliving that, and they're having to have more. The reason that we have so many people needing knee replacements, it's not the only reason, but the main reason for knee replacements is, it's a big reason, is obesity. So with each extra pound of weight, it puts a proportional amount of pressure on the knees. This is why they say even losing a little weight can not only help all of your metabolism, it can really help your knees and your joints. So knee replacement. The most common injury to the knee is the anterior, so the front cruciate ligament that is helping to stabilize that knee. Oftentimes we can have medial toward the midline, so this is on the inside of the knee, medial ligament damage, but also lateral. Their meniscus in the knee, so they can get torn. These little extra pads, it would be like thinking about your cushion in your chair if something just ripped it apart, and then if it ripped it apart, now the cushion's not so cushiony, right? So they can go in and actually do arthroscopic surgery, which is sort of minimalized invasive procedures, not like opening the whole capsule up. They can go in and repair the meniscus. They can sometimes also repair ligaments and tendons that have been injured in these joints as well. So you'll read that deeper insight, I'm sure. Ankles, again, you can see the complexity of the movement that we find at the distal end of the tibia. With the talus is the first tarsal bone that the tibia actually articulates with. The calcaneus is a tarsal bone as well. Remember, all the tarsal bones have names, but I only had you know a few of them. The calcaneus is the heel, so the tendon here is the calcaneal tendon. This is often called the Achilles. tendon. Sometimes people, when this gets inflamed, we know this is called plantar fasciitis. So this is actually inflammation here at the heel, and it's incredibly painful, pretty common too as well. So you can just see the complexity of this ankle joint. We had talked about Pestplanus, which is actually flat feet. So these ligaments that we think of that stabilize the arch are not as tight as they need to be, which causes the foot to kind of collapse down, so that as pressure is put on the heel to make a step, instead of dispersing it across the foot, it's just flat. So it ends up putting undue pressure on the entire body, really. This is why Pestplanus can lead to not only leg aches, but back aches and even headaches. Now, as far as arthritis, I told you this is just a broad term for pain. Osteoarthritis, here it is the wearing and tearing, the old age arthritis is the most common. Rheumatoid arthritis is an autoimmune disease. There are many others, autoimmune diseases, that can attack the joints. Arthroplasty is the replacing of diseased joints with artificial devices. And I want you to know the term, and it's not in your notes, I don't think, which is sad, called ankylosis. This is in your table of disorders. Ankylosing arthritis is when you have this type of arthritis occurring, where there has been so much damage and inflammation in the joints that any movement, even movement you can't see, is causing pain. It's causing pain and swelling, inflammation, swelling, and no movement is happening really that's effective. So in ankylosing arthritis, they will often, the only real treatment is to go in and try to fuse the joints down. And fusing them is keeping any movement from happening, which is hopefully keeping the inflammation at more of a manageable level. So ankylosing arthritis is what you're seeing here. This can happen in any joint. This can happen in the vertebra, the vertebral column between vertebra. It can happen in any type of joint. So again, these joint prosthetics, orthopedic surgery is really a interesting type of surgery if you ever get the opportunity to go into a surgery where they're replacing a hip or knee or shoulders. It can be interesting, just the sounds of the saws and the bone fragments. But anyway, this has been your lecture on joints. I hope you found it interesting, and there's a lot of terminology to use and to learn. So good luck, and until the next time, I'll see you then.